those to come up, we can go ahead and get the introductions done. I'm Andy Vernon from CDC. I work with the TB Trials Consortium, and this is
Norbert Heinrich from Munich. I work with Panacea.
So we each submitted a symposium proposal. We just invited the smartest people we knew who would have something to say. And the union asked us to combine the two proposals. So some of the smart people we know aren't presenting, and we had to pick the smartest ones. So that's what we've done. And as soon as we're ready to begin, we will start with Dr. Andreas Diakon from University of Stellenbosch in South Africa and the task group, who will be speaking about how critical is isoniazid, a study of the essentiality of isoniazid in early therapy of tuberculosis.
Thank you, Andy. To be heading this smartest group of the smartest is really the greatest honor I think ever had.
Well, we start and build up.
All right, so now I have to concentrate on this talk here. So how critical is isoniazid, and is this how one advances then? Yeah, okay, it does. So I have to thank Bill Bishai here a great deal for about half of the slides that he gave me about study A5307, which was titled Essentiality of Isoniazid in Tuberculosis Therapy, and it's one of the reasons I stand here now. You see who will help that. I don't have the time to mention them all, and I also have no conflicts of interest to declare. I can say that here. And some people criticize me after my talks if I don't show a car, so I've decided to just do this as well, like the conflict of interest form. So this is the car that I usually showed about ethambutol, which was the last drug we ever added to our primary regimen in 1961. And because I'm talking about isoniazid now, which is even older, I can present you this one. So this is the one that won the Formula One championship in 1952, which is when we had isoniazid for the first time in a clinical trial. And this is the level of technology, right, that we are currently giving to our patients. So the background of this A5307 study was to test the essentiality of isoniazid. Do we actually still need this old compound? It's what, 50, 60 years old? So we know that monoresistance out there is at 10%, and we know that it gives a rapid kill in the first 2 days, and then actually it seems that it doesn't add much. And it's also in a mouse model antagonistic to Riv and pyrazinamide, which is at least Bill Bishai, who comes from a background where mouse studies are often done, a very important thing to test. So this is to illustrate point 2 about the rapid initial kill. This comes from this landmark study that Amina Jinani did in 1980. You can see the isoniazid drop, and it's actually 2 superimposed curves. It's isoniazid only and isoniazid with rifampin. It's really a very steep initial drop, and then it plateaus out. So it's 0.7 logs of CFU per day that it drops in the first 2 days, and after that it's much flatter, about 0.1 logs per day for days 3 to 14. And this is the full table out of this paper. It just perhaps shows you a little more how this looks. So the big dot there, this is isoniazid alone, 0.7. And then every regimen and combination where an age is part of has a similarly high ABA, whereas the combinations that don't have isoniazid don't have this high plateau. So isoniazid is also dominating the EBA of each regimen that it's part of. And this is the point about the mouse studies. This is really just Bill's slide. I can only read to you what's on it. So this is what you get with rifampicin and pyrazinamide alone over 8 weeks in a mouse model. And this is what you get if you actually add isoniazid. So the activity gets less, and the more isoniazid you add to the regimen, the worse this antagonism in a mouse model actually becomes. So this is to just document the hypotheses behind it. And so we did an early bactericidal activity study, and for those of you that don't know what this is, just quickly explain here that we find patients like the one you see this chest radiograph up there. We find these patients relatively easily. We select the so-called healthy TB patient, so someone that has an X-ray like this but does not have any other medical conditions that making unsuitable for a medical experiment. Then we collect sputum overnight, and we give drug, and we keep measuring the CFU counts over time, and then we hopefully get a curve of diminishing CFU counts over time that we can describe in some statistical manner. So this is how an EBA study works. And now this 5307 EBA study was done with 4 groups. And so the original slide is from Bill, and these little graphs on the right are from me. So we would give these the normal standard regimen in 15 subjects. That's top of the table. And we would expect a steep initial drop and then a flatter continuation. This is what I showed you we would expect, right? And then in a second group, we would eliminate the isoniazid from the second phase. So this would give us a steep initial drop, and it would remove the antagonism from the second phase so that it would then be steeper. And in the next group, we replaced isoniazid with moxifloxacin, which might then actually give us an additional effect in the second phase, so it might drop in the second phase even more, like it says on the picture. And in the last group, we eliminated isoniazid entirely, which would remove that kink in the curve. So that was, I'm sure this is probably better described in numerical terms, but this is what we actually wanted to show. So the demographics of the study, and this is what we always see when we do EBA studies in our area. It's the average patient is now about 30-year-old male who is most likely not HIV positive and is slightly underweight with a BMI of 18.9. And they have a Karnofsky index of 90. So they're really healthy TB patients. If they weren't in our ward, they would go to work. You know, this type of patient. And they all must be smear positive to guarantee that we actually have something to measure over the 14 days. So they start off with a relatively high mycobacterial sputum load. And this is the result of the study, and this wasn't entirely what we wanted, because that blue line here that is marked RHZE, it is just flat. And this is now, of course, a problem because all our hypotheses can't be tested if we don't really have a kink to look at. And yeah, so we were all a bit disappointed. It's, of course, the experiment worked. Everybody has diminishing counts in the expected range. So the drugs worked, and everything was done right, but we couldn't really draw conclusions from this. And this was, of course, a bit odd. And I was thinking afterwards, what could actually be happening here? And one thing that I came up with is, if you compare this now, in the study that Amina Jindani did, and I showed you that picture before with that red arrow, the baseline mycobacterial counts were about 7.2 logs. And the study we did, it's about 6.2. And I marked that point of 6.2 with that bar there. I'm sure, does this work? Here. And now it doesn't take much of imagination to actually extrapolate from here to there that it's also flatline. Eh? So I wondered if this initial 2-day drop is not just a function of the initial count, you know. So I convinced one of my registrars that works on the ward to look into this and to look at all the data we've ever generated in all these EBA studies that Peter Donald did at his time, that we did from 1992 to 2015, when we found a total of 182 participants that had INH-based regimens or INH. And these studies are actually very simple. You know, it's always the same area, same lab. There's even the same lab techs that are still doing the same essays in the same lab, and we recruit people from the same area with the same criteria. And see just what happened over time. And this is a trend that is clearly statistically there. In the studies done up to the 2000s, the baseline counts were around 7, like the Jindani paper had. And nowadays, since 2005, when I started doing this, we get baseline counts around 6. This is a trend that we can't really explain, but it's a fact. And we also looked at whether that baseline count really had an influence on the EBAs we measured, and there's a very clear and statistically highly significant correlation between the INH EBA on the first 2 days and the baseline counts in all these groups. And this is now submitted for publication the 8th time to a reputed journal this time, because everyone else didn't find that interesting. They just sent it back to us and said, "Oh, I mean, who cares?" So I hope this will one day be published, because I think it changes a lot. And we have in the recent EBA studies, we've always now used the baseline counts as covariates and adjusted for the baseline counts. We do that for about 5 years already, because we know that the baseline counts actually matter. And this is not the first time we formally looked at this. Okay, so this is A5307's conclusions. The EBA was similar in all the regimens tested with and without INH or moxifloxacin and across all time intervals. There was no initial steep decline. And Bill Bishai's and my conclusion was that in this study there is no reason to drop INH. And because this is now about INH in general, I thought I'll add some slides to perhaps show you reasons why we should actually give it. And the first one is actually that curve. Even if it only works in very high baseline counts, it will still, in those people, reduce infectiousness very quickly. I mean, it drops this, probably by about 50-fold the count of viable bacteria that someone coughs out in 2 days. And isoniazid is unsurpassed in this. So that's one reason why I should give it at least at the start. And then we have this that I call the sitting duck slide. It's very difficult to explain, but INH and resistant protection. INH is an interesting drug. It has, on the one side, it has a high frequency of spontaneous mutations. It's probably the one of all the drugs that has the highest. So this picture here is actually a bit misleading. The picture here, the spontaneous mutations in a natural sample would have about 1,000 isoniazid-resistant dots for one rifampicin-resistant dot, and not an equal number. And then because if the isoniazid kills its own, or the susceptible ones very quickly, it isolates its own resistant ones just as quickly. So at first there is a lot of isoniazid-resistant mutants around, and then isoniazid quickly kills everything else. And what stays is the isoniazid-resistant bacteria. And this is probably one of the reasons why we have such high isoniazid resistance rates. And then there is this other one that I'm always nervous to explain. This is Denny Mitchison's table, and the only one that I found published. There was in history one period where they gave one drug. That was very short because resistance development to streptomycin at that time was extremely quick. And then they realized, the physicians at the time, that giving drug combinations works for resistance protection. And eventually one settled at 3 at least. And there was a period in history where 2 drug regimens were given. It was brief, and this data is all about this. And here, this table is the failure rate, means the failure of a drug to prevent isoniazid resistance. It is known that if you give isoniazid alone, you end up with about 50% isoniazid resistance. And in all the other 2 drug combinations, it was always isoniazid that becomes resistant, because the other drug fails to protect it. And this is the scale. So rifampicin protects relatively well, when isoniazid protects excellently. Rifampicin second best, streptomycin third, ethambutol fourth, and so on. So from the data we have, and you will never be able to do this again. You cannot ethically treat people with substandard regimens just to observe who protects whom and who creates resistance in these drugs. So this is the best data we'll ever have. And isoniazid is the best protector from resistance. And then this is just the last one. In this study in Madras, 1960, they treated patients with isoniazid alone. And these groups here are all different levels, different treatments with isoniazid alone. And you can cure 50% of people with isoniazid alone for a year. So there must be something in this drug. It actually does sterilize people at some point, somehow. And that's also something we will never be able to do again. But it leaves behind, if you give isoniazid for 1 year, you'll end up with 50% isoniazid-resistant patients that don't do so well, and 50% that are cured. This is, of course, poor medical practice, but the 50% that are cured will like it. Okay, so that's now the final conclusions from this study. Also, unfortunately, in that essentiality EBA, all EBAs were similar, probably, possibly, due to these lower baseline counts that we nowadays have. And there is no reason there to drop isoniazid in those susceptible. And you should keep giving isoniazid because it's good for infection control, it protects the companion drugs, and it contributes something to sterilization. And that's where I stop, and I just thank the sponsors of this A5307 study and everybody else who helped. Thank you.
Invite a question or two, Patrick? Sure, whatever you like.
Thank you, Andreas. So the REMOX trial was interesting because it had a regimen that didn't have isoniazid in. And there aren't many studies that have regimens that don't have isoniazid. And it was interesting because there was no difference in culture conversion between the two moxifloxacin arms over 12 weeks. But as we know, the arm that had isoniazid in had fewer relapses than the arm that didn't have isoniazid but had ethambutol instead. And I think some people have suggested that this might be evidence that actually isoniazid does have sterilizing activity, because there was no difference, at least in culture conversion, during treatment, but yet there was a difference in relapse rates. I don't know if you've got any thoughts on that.
Well, me having thoughts about the statistical evaluation of REMOX would be a bit arrogant, I think. But what I can say is that if moxifloxacin had been around in the 80s, on that scale of Jindani's EBAs, it would probably have scored almost as high as isoniazid. Those few data that we have about moxifloxacin, we know that it has a very good early bactericidal activity. So I wouldn't be surprised if it has a similar contribution to overall treatment that isoniazid has.
Isoniazid added something.
Yeah. Yeah. Look, I'm not here to tell you shouldn't give isoniazid. I agree with you. Keep giving it to those that are susceptible, at least.
Thanks, Andreas. Very nice, interesting information. But I wondered if you think you tested the hypothesis that isoniazid antagonizes the regimen adequately with that design. Should you not have gone to at least a month?
Yeah, perhaps. Yes, good question. One would have to do it. It is something we've never done. But if you give drugs as strong as this for a month, you'll probably end up with many culture-negative individuals at the month. And to really do an analysis like this that relies on detecting small differences, you probably need a full data set of quantitative data. And I think you would run out of CFU counts, and the variation would become so large that even you do it longer, but the variation gets so big that you still can't detect the difference. That's my guess. It could have been done. Usually we are confined to 2 weeks in EBA studies with monotherapy, because then there is this possibility of resistance development. But with these combinations, we could actually have done this. Yeah. That's not a very helpful answer, I know, but I will think about it next time.
Thank you very much. Any other questions? No. Thank you, Dr. Diacon. Our second speaker is Dr. Kelly Dooley. Kelly is a pharmacologist and TB physician at Johns Hopkins, and has rapidly become evident as one of the leaders in this field, in the TB field, along with a small group of others, at least one of whom is here also. And she'll be talking about optimizing rifamycin and PZA doses derived from trials and models. Part of the presentation, I believe, is a lot of it was done in collaboration with Dr. Rada Savage, who is not here, I don't think. Kelly?
Great. Yeah, so as Eric points out, I'm apparently the second smartest speaker in the series today, so we'll see how we do. So I'm going to talk about optimizing rifamycin and pyrazinamide, because although some have suggested during this conference that we're in the post-rifampin era, I would argue that we probably are not, and we will continue to be for some period of time, and if not now, we'll eventually come back to it in the future. So So I'm going to tell you today about two different stories. The first story is about pyrazinamide, and the second is about rifamycins, and just asking how we can use these drugs a bit better, and then if so, how. And so the first is this nice collaborative effort we have between Panacea and TBTC, pulling together the data from recently published clinical trials to try to answer the questions about pyrazinamide, namely what is the relationship between drug exposures and outcomes, as well as what is the relationship between drug exposures and toxicity. And you can see some of the main members of the people that have been working on this collaborative project. And then, of course, the Panacea and TBTC networks are large networks with many contributors, all of whom are not named here. So I'm just going to take a little bit of a walk back through history, kind of the way that Andreas did, and tell you a little bit about pyrazinamide, because we all use it. It's been used for a very long time. But you know, how did we get to the doses that we're giving today and that we're using today? And so if you go all the way back, before rifampin was developed, we had pyrazinamide, and so people thought, well, what could we add to isoniazid to get a good treatment response? And you can see here that if you give 3 grams of pyrazinamide together just with isoniazid, that you get about an 83% culture conversion rate. And then, still in the pre-rifampin era, you can see here that if you give a dose of pyrazinamide that's 20 to 30 milligrams per kilogram versus 50 milligrams per kilogram, together with isoniazid, that you get a lot better effect with the with the higher dose in terms of therapeutic efficacy. And you also see that people had cavity closure, they had protection against resistance, and cure in most patients in these early trials. Then if you take it further, so then the question was, okay, now we have pyrazinamide, rifampin is here, which drug is better? So if we're going to have a regimen that has streptomycin and isoniazid, what should the third drug be? And so you can look back at these old trials and see essentially that if you give either rifampin, pyrazinamide, or thiazidazone, that rifampin and pyrazinamide both do equally well, and the toxicity was relatively low. So this just demonstrates the really strong sterilizing activity of pyrazinamide. So then now, okay, they both do very well, but then the trials turn to, okay, well, what about if you use them together? What kind of effect can you get? And you can just see here that if you add pyrazinamide at a dose of 35 milligrams to 40 milligrams per kilogram in the first 2 months of chemotherapy, that you really are able to shorten treatment from 9 months to 6 months. And you can see that the relapse rates for those regimens that don't have pyrazinamide are much higher than those that do. And so on the basis of these trials, pyrazinamide was added to standard short course regimens. But you can see that somewhere along the way, even though the dose of pyrazinamide that allowed us to shorten our TB treatment, the doses recommended by WHO changed from 35 to 40 mg per kg to 20 to 25 milligrams per kilogram. And so you can see in more recent trials or recent studies that those patients that tend to have lower pyrazinamide concentrations really do less well. And so this is just looking at this target of 35 milligrams per kilogram of pyrazinamide and those people who achieve that target and do not. And it seems like they do less well if they aren't getting those levels of this drug. And so this is another study showing pretty much the same thing, that they're about equal good and poor outcomes among those patients that get pyrazinamide at this particular AUC design shown in this study. And so then the question is, well, if you think that probably higher doses are better, then what is the safety of those higher doses? And so this was looked at, way back in the day when people were evaluating this. You can see in 1959, and if you give a dose of 40 milligrams per kilogram for 6 months, you have about a 7% risk of hepatotoxicity in the way it was measured then, whereas if you give the drug either at the same dose for a shorter period of time or at a lower dose, you get much lower risk of hepatotoxicity. So it seems like the therapeutic margin for pyrazinamide isn't that well defined, but it's probably somewhere the right dose is between 20 milligrams per kilogram given for a couple of months and 40 or 50 milligrams per kilogram given for 6 months. But we don't know really where in there we should be. So to try to answer the question about the relationship between drug exposures and outcomes, as well as drug exposures and toxicity, we pulled together these nice data sets And Rada Savage did some modeling work for us. And so these are the TBTC trials, studies 27 and 28. And these were trials to see whether we could substitute moxifloxacin either for isoniazid or moxifloxacin for ethambutol and get better treatment outcomes. In these trials, the pyrazinamide doses were 20 to 25 milligrams per kilogram. There were 72 patients that had PK data, and then liver functions tests were collected throughout the course of treatment. And so you can see from these kind of preliminary analyses that as you can see I don't know how to do this exactly. Maybe, okay, so these gray lines show the range of exposures you see with the doses that were given in the trial. And you can see that, so there's a broad range of exposures. And then you can see that as the maximum concentration of pyrazinamide goes up, the proportion of patients that have a 2-month culture conversion goes higher. And so among those patients that receive 2,000 milligrams, then this would be the model-based prediction of 2-month culture conversion versus those patients that receive a lower dose of the drug. And you can see on this graph here that the time to culture negativity also is increasing as the maximum concentration of pyrazinamide increases. So this is nice. So this is with just standard dose rifampin. Both of these trials did not have an increased dose of rifampin. But then the next question is, well, okay, but we're trying to optimize rifampin, and people are interested in higher doses of rifampin. So if you give rifampin at high doses, then maybe you actually don't need to increase the pyrazinamide because you're going to get the effect out of the rifampin. And so this... So then the Panacea Network was very kind enough to share these data, and of course Rada Savage did all of this modeling. And so in the Panacea trial, which was just published on Wednesday, I think, and today's Saturday, they showed the results of this 5-arm trial, and essentially the rifampicin doses range from standard 10 milligrams per kilogram all the way up to 35 milligrams per kilogram, and the pyrazinamide dose was 25 to 30 milligrams per kilogram. So we have demographic data from all of these patients, and then PK sampling in about 100. And you can see these are also very preliminary results and model-based results, but you can see that, for all of the, so for a patient that is taking a rifampin 10 milligram per kilogram dose, their average maximum concentration of rifampin is this gray line. And so you can see that as the pyrazinamide exposure increases, that among those patients that had the lower end of exposures for rifampin, that the culture conversion improves. But you can see that the same is also true among those patients that had pretty high exposures to rifampin, because more or less they got the higher doses, and that the relationship between pyrazinamide AUC and 2-month culture conversion also persist here. So it's not just the people that have low doses of rifampin that could potentially benefit from higher doses of pyrazinamide. So then the question is, well, is it safe? So within the range of doses given in these trials, and granted this was not a broad range of pyrazinamide doses, and the variability is actually much lower than with rifamycins, but you can see that there's not really any trend. And if you take, these are the quartiles of maximum concentrations of pyrazinamide, and you can see that as you get higher exposures, you're not seeing any trends toward an increase in AST or in liver function enzymes over the course of treatment, and you're not seeing a lot of people up here, these outlier individuals with really high LFTs. So at least this is somewhat promising within the range of doses that were tested, and the same is true of bilirubin, although I don't have that slide. Okay, so that's pyrazinamide, and so now we're going to switch gears a little bit. I guess that's pyrazinamide, and it's also a little bit of rifamycins, because as you increase the rifamycin exposure, you do better, and as you increase the pyrazinamide exposure, you do better. We might be able to co-optimize these drugs and do better with first-line treatment. And so now I'm going to talk a little bit about the developing story of rifapentine. Oh, I forgot to start my timer. Darn, that's bad when I do that. Okay, so I'm not really sure how long I have to tell you this story, but this is the story of rifapentine, which is a cousin drug to rifampin. It has a longer half-life, as you can see, and its MIC against M. tuberculosis is lower. So overall, we thought, based on these characteristics of the drug, as well as some early mouse studies in a very well-validated mouse model, that probably rifapentine would be a better drug than rifampin, and that probably in the same milligram per kilogram, maybe we could get better effect. It would, in fact, potentially be a blockbuster. And so here is study TBC C29, in which an empiric dose of 10 milligrams per kilogram, which gave exposures in people that were similar or maybe a little bit lower than in mice, but not substantially. And you can see that replacing rifampin with rifapentine, both given at 10 milligrams per kilogram, gave you essentially the same results on liquid and on solid media. And so the TBTC network then went back to say, okay, well, we need to do some dose finding in people and figure out really what is the right dose of this drug that we think is quite potent and probably will do quite well. And this is study 29X. And you can see here that these are the results of that effort. And those patients that got rifapentine, whether it was 10, 15, or 20 milligrams per kilogram, all had extremely good 2-month culture conversion, so ranging in the 90 to 95% compared to rifampin that had an 81% 2-month culture conversion. And I should say that even in the 10 milligram per kilogram dose, people got the dose 7 times a week instead of 5, and the dose was given with food. So essentially optimizing the exposure to drug, not only through drug dose, but with frequency and with food effects. So that was very promising, but just one thing came to light when Radha Savage and Mark Wiener were doing these subgroup analyses, and you can see that among those patients that have it's not really doing anything at this moment because I'm pushing the wrong place. Okay, so that among those patients that have large cavities in their lungs, even if they have a relatively high drug exposure, and it's not dependent on if they're on geographic setting, that those patients tended to have, the percent of patients that convert their cultures at 2 months is much lower than those patients that did not have cavitary disease. And so this was a little bit concerning that potentially those patients that have large cavities may not benefit as well from rifapentine as other patients. And so the second question was, well, can we learn something about drug distribution and of rifampin versus rifapentine and how these drugs get into cavities, and will that help us in any way to understand these clinical trials and perhaps to predict patient groups less likely to benefit? And so this was work done in Bill Bashai's laboratory by Dalan Rifat, also with a very nice collaboration with Véronique Duartois' group and Sanjay Jain's group at Hopkins, and Radha Savage also did all of this modeling. And essentially, so what Dalan did, she developed this rabbit model. I mean, there have been rabbit models in the past, both at Rutgers and as well at Hopkins, but she used a bronchoscopic method to infect a certain number of bacilli into a lobe of the lung, and she did these dose-finding studies, or these infection-finding studies, where you give a lot of bug, then the rabbits die. If you give not enough, then they develop a disease and they clear the disease, but there's just that right amount that allows you to develop a cavity relatively reliably. And so this is the kind of thing that you see in this rabbit model. So this is the bronchoscope in B, that's the bronchoscope being injecting the bacilli, and then you can see that you get these nice cavities with really like juicy pus in the middle of them, which is really what you're aiming for. And so this is just to show you the differences between, and these MALDI images are from Véronique's laboratory, but you can see that if you give rifapentine as a single dose or as multiple doses, that in these necrotic centers of these cavities, you're really not seeing much drug. Whereas with rifampin, you give a single dose, you don't get a lot of drug penetrating into these cavities, but then as you give multiple doses, the drug actually tends to accumulate within these lesions. And so you can see that this is just the quantitative readout of this, that as you give rifampin, it takes a while to actually distribute into the lesions, and it tends to accumulate over time, but with rifapentine, you don't really see that so much. And so then, if we go on to do to do mass spec and quantify the drug in these different compartments, you can see that for rifampin, the concentrations of rifampin that are in the plasma versus in cellular lesions, in tissue around the lesion, in the caesium of the cavity, and in the cavity wall, it's about 1-to-1. So the drug penetrates quite nicely, whereas for rifapentine, the drug gets in very well to the cellular lesions, the tissue and normal lung, but in these cavitary centers, it's about a quarter of what you would see in the plasma. And so then if you take it back and you put this site of action pharmacokinetics into these PK/PD models, what you can do is say, okay, those patients in TBTC trial 2029X who had cavities that at the site of disease, their concentrations were about quarter of what they had in their plasma, whereas those patients that didn't have cavities have site of disease pharmacokinetics very similar to what they have in plasma. And then you rerun these PK/PD models, you can see that you have statistical significance here. And what you can do that's further, I think, more important is to figure out a site of action target exposure, and that looks to be about 200. And that's fine, that's easily achievable with the dose that's in the phase 3 trial, although those patients who have large cavities, probably they need to have levels of about 800 in their blood to get about 200 at the site of disease. Now, this doesn't take into account the fact that over time with treatment, people's lung disease changes, whether or not they have cavities changes, and this is all a dynamic process that we didn't capture in these rabbit models. So I'll just summarize by saying that at the currently used pyrazinamide doses, target concentrations are not being achieved by a large proportion of patients in the world, and this is associated with worse clinical outcomes. We have some evidence from recent TBTC and Panacea multinational trials on multiple continents showing that the efficacy of pyrazinamide is increased as the exposures to the drug is increased, and this was true whether or not it was put together with standard dose of rifampin or higher dose rifampin. And within the relatively narrow range of doses given, there was not any evidence that exposures were related to hepatotoxicity. We think that these data support evaluation of higher doses of rifampicin together with an optimized pyrazinamide dose within a relatively reasonable range. Rifapentine is a very promising drug. It's in phase 3 trials, and a lot of us believe that it will do very well, but it does diffuse poorly into these large cavitary lesions, and so that patient subgroup is a subgroup that requires specific attention. And then just the last point is through clinical data sharing among groups and smart use of preclinical tools and mathematical modelers that are sophisticated, we hope we can better understand and predict treatment responses and thoughtfully choose those drug combinations that we should take forward into the next generation of trials. Thank you.
We are losing ground time-wise, but we would like to entertain a question or two for Dr. Dooley, please.
Thanks, Kelly. Just going back to the question of pyrazinamide dosing, when you showed potential toxicity issues associated with changing those, we always look at hepatotoxicity and ALT levels. When you manage patients, sure, some of them have that as a serious problem, but that's not what they complain of. They complain of joint pain and sort of lower grade, harder to quantify and measure toxicity concerns. So I guess my question is, what do we know about whether changing the dose of pyrazinamide or giving pyrazinamide for longer will mean in terms of tolerability for patients rather than a single cut-off hepatotoxicity measurement?
Right. No, that's a very good question. So, I mean, even in these old studies, we had these tests that are tests we don't really know how to understand. And the liver toxicity is the thing that you fear the most, obviously. But the thing that allows a person to finish their treatment course, which is, of course, the greatest predictor of how well people will do, is tolerability. And so I don't think we know anything about the relationship between drug exposures and tolerability and treatment completion. So I think that's really important. I think any trial that has a higher dose of pyrazinamide will need to have tolerability and drug discontinuation as a primary outcome. Because, yeah, you may not see the liver toxicity, but if people feel terrible with a higher dose, then that's unacceptable. And then the other question is, should pyrazinamide be carried out longer than 2 months, right? If you're going to try to do a 4-month treatment shortening, how well will people tolerate this drug for longer periods of time? And that all is unknown, but really important. Yeah.
Yeah, Nicolas Vézérus from Paris. So the data on the difference of penetration between rifampicin and rifampicin is really impressive. Is there an explanation for this difference? An hypothesis, or why it would be different?
Is this something you're going to talk about, Veronique? So all of this, a lot of this work, as you may know, is done in Veronique D'Artois' lab, and they've developed a sort of a casium, and they're trying to determine which physiochemical properties of drugs impact the way that drugs can diffuse into casium, and it certainly goes beyond protein binding. It's much more sophisticated than that, and she's published a paper and maybe could speak to that a little bit better than I could.
Although certainly protein binding would be a good first place to start for that huge difference, since there's a 15 to 20% difference between the two drugs.
It is a major determinant. We've just discovered that it's a bit more complex. Initially, we thought we could get away with binding to actually macromolecules in casein as a driver of pore diffusion. But rifampicin is the magic, it sits in a magic spot. And we're trying to understand why it sticks there.
Okay. Well, I hope you're going to talk about the magic after Eric. Thank you. Thank you, Dr. Dooley. Our next speaker is Dr. Eric Nürnberger. Dr. Nürnberger is one of the leading animal modelers globally, working with all kinds of mice and TB and other species as well. And he will be speaking about mouse tails and their predictions, building on the example of clofazimine.
Great. Thank you both very much for the invitation to speak. It's really a privilege. I appreciate everyone sticking it out and persisting through this session. So given the limited time, I thought I would focus really just on the story, or the mouse tail, if you will, of clofazimine, a drug that's being examined as an agent suitable for repurposing against TB. But of course, in fact, it's not really repurposing in the sense that clofazimine was really initially discovered and developed as an anti-tuberculosis agent. And this was work that was led by Vincent Berry in a university just across the sea here. They discovered the remarkable activity of clofazimine against Mycobacterium tuberculosis, clearly described its prodigious bactericidal effects in mouse models of the day. What I'm showing here is not actually a mouse model of the day. But a typical result in a mouse model where one sees several log kill over several months of activity. And it's for a much longer talk, but this was actually a very august and thoughtful group, and these are really great reads, these old papers, because they really had a lot of insight into what ultimately proved to be the mechanism of action, and a lot of really interesting thoughts about the drug distribution and the impact on the activity. And this would be one place where I would refer you, this Boyle Medal lecture. But unfortunately, there was a premature sunset on clofazimine and its development for tuberculosis. And this occurred really as investigators tried to move from the mouse model and in vitro studies to really look at it in disease models in which there were more caseous lesions, more diverse lesions in the tissues. And to be sure, all of these studies were limited in one way or the other. And to sum it up, in lesions like the guinea pig and the macaque, where again one encounters more diverse caseating lung lesions, clofazimine was effective as prophylaxis. If you loaded the tissues before infecting the animals, it was very effective at preventing the development of disease. But if given in an established TB infection, it performed very poorly. Now, I mentioned these were all limited studies in some sense or another. They were compromised generally by poor bioavailability of the formulations with clofazimine. They often focused on very early endpoints like prevention of mortality or reduction in pathology, as opposed to actually looking at effects on the organisms. And an interesting point about the macaque experience was oftentimes an initial clinical response was seen in monotherapy, but ultimately it looked like resistant mutants were selected out. Shift in susceptibility was demonstrated for the majority of isolates at the end of the treatment. So this tells us, of course, that the drug was exerting some selective activity and that the drug was active in some sense in those models. But really, the dawn of clofazimine ended being spectacularly overshadowed by the efficacy of streptomycin and INH-based regimens that emerged in the 1960s. And of course, it wound up being a drug that used around the world to treat leprosy. And it really wasn't until the obviously influential Bangladesh regimen publication in 2010 that interest in clofazimine really truly became revitalized. And of course, this was an observational experience under programmatic conditions, so it has those caveats. But the nice thing was it was a very clear stepwise development of the regimen that these patients received throughout. So one can at least get some sense of the contribution of clofazimine to the regimens by looking at the difference between group 4 and 5, which at least in terms of the drug treatment, was largely defined by the inclusion of clofazimine. And there appeared to be a benefit in terms of the number of successful responses. Now, Jacques Grosset, we had started to look at clofazimine also under the TB Alliance combination study program, and I must say Jacques was really a very early detractor of clofazimine and its potential in tuberculosis, and that was largely based on his experience treating MAC infections largely in mouse models. And so he was asked by the union actually to do some mouse studies to try and determine the contribution of clofazimine to regimens like the Bangladesh regimen. So, he really set out expecting not to see anything very impressive. And this is just an example of an experiment that was done with a second-line regimen. This is amikacin, moxifloxacin, ethambutol, and pyrazinamide against an INH-resistant organism that also had some reduced susceptibility to pyrazinamide. And then in green shows the same regimen, but with clofazimine added to the regimen at 25 milligrams per kilogram. And so, obviously quite impressive is the stalling out of the activity of this regimen with the removal of amikacin at 2 months and the impressive continued effect of clofazimine during that continuation phase. And more or less all of the mice were cured at the 8 or 9 month treatment point. And so, that was just some of the relapse data. So there have been, of course, a few more observational studies and one clinical trial that's attempted to look at the impact of clofazimine on clinical regimens. And there does seem to be some evidence to support benefit in culture conversion and perhaps other endpoints like survival, although certainly not an ironclad case, I think one would have to say, from these clinical data. So Jacques and his team have gone on, of course, to look at clofazimine incorporated into a first-line regimen. And again, shown here in red is improved treatment response with the substitution of clofazimine for ethambutol. And this results in treatment shortening, looking at roughly 2 months here relative to the standard regimen, implying that clofazimine could well have benefits beyond second-line regimens. As I had mentioned, we had also been looking with the TB Alliance at incorporation of clofazimine into novel regimens, and this is an example of an impressive contribution of clofazimine to a bedaquiline pyrazinamide backbone. Note the comparator regimen here is a rifapentine pyrazinamide moxifloxacin arm, not the standard first-line regimen. This regimen itself is associated with a 3-month treatment shortening in the mice. And so here we're shortening treatment by another month with the addition of, compared to the control regimen with the incorporation of clofazimine into this combination. And it was this set of mouse studies that then prompted the NC003 trial that was conducted by the Alliance, which included this bedaquiline, pyrazinamide, clofazimine regimen. And the reason I show this is because this also was a trial in which clofazimine was examined in monotherapy, under the assumption that all of the drugs that have previously shown utility in the treatment of tuberculosis have demonstrated some early bactericidal activity, at least over 14 days of treatment. And so, the real stunner here, which has led to a lot of consternation and a lot of discussion about the role of this drug, was the fact that it had absolutely no early bactericidal activity. So another reason to think twice about the potential contribution of clofazimine and the question as to whether we really can move from the mouse and try to translate to humans came from a series of experiments comparing results with clofazimine in BALB/c mice, a very standard mouse model, and the Kramnik mice, this strain of mouse that actually does develop caseating lung lesions. So here we are going back again to the question of how well does clofazimine perform when there are caseating lesions. And so this is a very nice set of figures from Veronique in this lovely review. And so what I want to illustrate here is this is what every lesion in a BALB/c mouse model looks like. It's an entirely cellular lesion. There's really essentially no necrosis. All of the bacteria are inside macrophages, either these foamy lipid-filled macrophages or the macrophages that have come in to form a larger outer ring. And so the bacterial population is entirely intracellular. Now, in contrast, for the Kramnik mice, they have cellular lesions like this, but the bacterial burden resides predominantly, or at least the largest portion of the bacterial burden lies within these caseating lung lesions. Now here we really have two sublesional compartments. There's probably lots of nuance here, but just for the purposes of this talk, we want to think about two sublesional compartments. Again, you have the infected macrophages where the bacteria are intracellular. They're lining this cuff around the necrotic area. But you also have within the caseum large numbers of extracellular bacilli. And my one knock on this figure is that there's, at least in terms of the Kramnik mice, there should be many, many more acid-fast bacteria inside this caseous region where the extracellular bacteria really dominate the total bacterial population in the lungs of the mice. So we can use these two mouse strains to sort of interrogate the role of the caseous portion of this lung lesion and how it affects the performance of clofazimine. So these were studies led by Ann Lennertz and her group at Colorado State. So this is a monotherapy comparison of clofazimine in BALB/c mice versus the Kramnik mice for 8 weeks of treatment. So this is a subacute infection model. And what I'm just illustrating here is the effect size, the reduction in CFU relative in the clofazimine treated relative to the controls. And so you can see that in the lungs, in BALB/c mice, 4-log kill versus a 1-log kill in the Kramnik mouse. Profound difference in terms of the overall cidal effect. So one then would think that the caseous lesions must play a role. How can we examine this further? Well, you could also look in the spleens of these mice. In the spleens, caseous lesions don't develop. So you're really just looking in the same mice at the intracellular infection compartment. And here, I just gave you the arrow and the number because the scales here are a little bit different. So it's essentially the same effect in the spleens across the two mouse strains. So if you look at the intracellular population specifically, and in isolation, the effect is largely the same. The other way that this was looked at was to start treatment either early, at 3 weeks after infection, before the caseous lung lesions had developed, where again, all the bugs are predominantly intracellular in the Kramnik mice, versus starting later after these caseous lesions have developed. And again, a very profound difference in terms of the CFU counts in untreated versus clofazimine-treated animals. So clofazimine does work in Kramnik mice. It only works against intracellular bacteria, largely speaking, and doesn't work very well in the caseous lung lesions, is the implication that one could draw from this. So why might that be? Well, clofazimine is a very unique drug. This is a very lipophilic drug with some remarkable physicochemical properties that really determine how it distributes throughout the body. It has a very long time to steady state. When dosing with a single daily dose, it'll take well over 1 month, maybe even into the 3rd month of treatment before one reaches steady state plasma concentrations with the drug. So on that score alone, it's going to be some time until it reaches its maximal effect. But the drug is also very unique among TB drugs, at least, many TB drugs, in that it accumulates very markedly inside macrophages, and it undergoes what's called pH-dependent ion trapping. So it gets protonated and gets trapped inside the acidic phagolysosomes of macrophages. And this is, importantly enough, where persisting M. tuberculosis bacteria might reside. Now, Veronique's going to talk at a great length again about distribution of drugs into caseum. So I'm not going to belabor that discussion, but suffice it to say, again, clofazimine, by virtue of this very high lipophilicity, as indicated by the high C log P value, is a drug that does not diffuse very well into caseum, presumably in part related to nonspecific binding to the components of the caseum, but does accumulate, as we discussed, very markedly inside macrophages. And so as opposed to pyrazinamide, which distributes very well through the caseum, you have this big blue lake, which shows very low clofazimine concentrations, at least relative to the surrounding portions of the lung. And I'll point out here with the next slide in a little more detail where clofazimine does accumulate. These red spots are areas of high cellularity in the areas around the lesion. So the accumulation is largely going to be inside macrophages and other cells, as opposed to being able to reach organisms inside the caseum. Or if it does, it'll reach at very low concentrations. And so Veronique and her group also did quantify a drug. And here you can see it's bad enough for rifapentine. Here's the ratio between cavity wall and cavity caseum in patients who had received clofazimine for months prior to being sampled here. Now, these levels are low, but they're not zero. These levels are roughly in the 0.25 nanogram per gram. I'm sorry, the 0.25 microgram per gram concentration. So right about the MIC, although there's probably a great deal of binding, so the free drug concentrations are perhaps not that high. So drug distribution is probably an issue into caseous lesions. The other issue may be, the reason for this disconnect between what happens in necrotic lesions and what happens in intracellular lesions could also be somewhat dependent on the mechanism of action. Without belaboring this, clofazimine does appear to work, at least in part, by generating reactive oxygen species during this redox cycling pathway that goes on, where it takes electrons from reduced minoquinone and donates those electrons to molecular oxygen to create reactive oxygen species that then can kill the bacterial cell. Now, this is most likely to happen when molecular oxygen is abundant. So under the hypoxic or rather even potentially anoxic conditions encountered in some of these lesions, we would expect this mechanism of action to be less marked. Now, there may be other mechanisms of action. It also appears to have some protonophore activity, which would potentiate its activity in low pH environments. And both of these activities, as well as potential effects on respiration, one way or another, may be in part another reason why this may be mechanistically a slow starter. And there's further sort of phenotypic evidence for this slow onset of activity, if you will. And these are a couple of studies that Nicole Ammerman performed in Jacques' group. And this has just been accepted for publication. So this was just looking at an in vitro and an in vivo EBA to look at the timing of the onset of clofazimine activity at different concentrations or different doses. And one sees here that even although one has to get to quite high concentrations to see a bactericidal effect in vitro, 1 to 2 micrograms per mil, that onset of activity may be quite a bit delayed, as much as a week before one sees to see that bactericidal effect. So reminiscent of what could also be seen with clofazimine, with bedaquiline. Now there's also, and this may be due to some of the same drug distribution concerns that we talked about earlier, there is also a delay in clofazimine's onset of EBA in a mouse model. So this is a short incubation, a rather acute infection of only 7 days before treatment is started. And in untreated mice, the bacteria continue to multiply quite a bit over the ensuing 2 weeks. And this is just to show you that at what could be considered the human dose equivalent in terms of AUC, the clofazimine activity is really quite negligible over the first 2 weeks of treatment against actively multiplying bacteria, maybe only beginning to register here. And so may provide, again, some corollary for the early bactericidal, delayed early bactericidal activity. So I've tried to illustrate reasons why there might be a disconnect between clofazimine activity in BALB/c mice and animal models with caseating lesions. We've talked about how clofazimine really efficiently targets only the intracellular persisting bacteria, which define the entire bacterial population in typical animal models. But the fact that it doesn't diffuse very well into caseum, that it may be less active under hypoxic conditions and maybe even under the high pH that's been measured in the caseum of Kramnik mice, and this slow onset of action, these may well be reasons that together explain the poor performance in the caseous lesions of Kramnik mice. Now, the question is, what does that say about how clofazimine would contribute to combination therapy? You know, these have largely focused on clofazimine monotherapy. I would suggest that most of the studies that have looked at clofazimine thus far in models of caseous lung pathology have really failed, potentially from experimental design issues, to deliver and reveal effects of clofazimine against the intracellular population of interest. This is a minority population, and so unless the treatment is long enough or is a treatment that is a combined treatment involving other drugs that do get into caseum and eliminate the predominating population in caseum, you may not reveal this activity of clofazimine against the minority subpopulation, a subpopulation that we know is at least important in persistence. I'm not going to call them the only persisters, but important in persistence, as demonstrated by the BALB/c mouse model. So I think these factors mostly also could serve to explain the lack of EBA over 14 days and this apparent disconnect with its again, apparent contribution to some of these clinical regimens. So I think that clofazimine really does still have substantial potential to contribute to new TB regimens. It targets intracellular bacilli. It has a sterilizing mechanism of action. It combines very well with a variety of drugs, Norbert, including BTZs. The issue is how best to examine this and to demonstrate this and to find a path forward. And I think to do that, we probably have to just accept the fact that its contribution is largely going to be limited to eradicating only the intracellular population, a minority population, but one that is likely still important to persistence and treatment duration. And that once we accept this, we should just see about focusing on the proper dose and duration to most effectively target this particular population, which arguably could be done in BALB/c mice, which really just typify this population. And then figure out how best to combine it with agents that complement its PK and complement its mechanism of action. And design experiments then in caseous lung lesion models that will really effectively test its contribution to the regimen by having other companion agents that'll take care of bacteria in the caseum and can allow you to focus through longer treatment duration designs to ask whether clofazimine still plays a role in accelerating the elimination of the intracellular bacteria. And the corollary for human disease, I think, is we really are going to have to focus our clinical evaluations on longer-term outcomes than a 14-day EBA study and look carefully at sputum sterilization and relapse rather than other early microbiological markers. And so with that, I'll stop. And
thank you very much. If it's a quick question, we can take one question, but I think we better move forward because we're close on time.
I mean, do you just think that Van Doon worked because it killed those hard-to-kill last bugs you have to eradicate, and the other drugs did everything else?
I think that's quite possible, right? I think it's quite possible. I think what we don't think about often is, what happens to lesions over time in patients on treatment. And I think, we have this conception that these intracellular bacilli that line the lesions don't contribute to bugs in the sputum or, sputum culture conversion and these sorts of things. But, of course, over time, these lesions are healing on patients on therapy as well. The sputum is being populated from somewhere. Some of these are bugs that are certainly replicating inside of cavities, but these cavities are also evolving, and I think bacilli are continually being dumped into the cavities in active lesions. And so, I think drugs with intracellular activity can affect sputum conversion and certainly can affect treatment duration and relapse.
Thank you very much.
So it's my pleasure to now announce Véronique Dartois, who heads a group at Rutgers University in New Jersey and has already taught us a lot about drug penetration into lesions and concentrations in the lesions in the past. So we're looking forward very much to hear what you have to say now.
Thank you. Thanks for the combined introduction. So I have no conflict of interest, and I guess I don't have to explain to this audience that tuberculosis is by and large the bacterial infection that takes the longest to cure in terms of drug days. And our group tries to understand and investigate the pharmacological factors behind the long duration of TB treatment. And when I say pharmacological, I mean the combination of pharmacokinetics, and this has been alluded to many times today, so that's great, fantastic introduction, and pharmacodynamics, which I will also talk about very briefly. So basically, we want to understand... Is dead.
You move forward with the other one.
Yeah, but the pointer is dead. I'm sorry. If you have another one. Otherwise, I will survive. It's okay. So I can continue without the pointer.
Push on the thing on the top there.
Oh, sorry. Okay, I was pushing in the wrong place. So basically, the big question is you see this pathology, which most of you are familiar with, and we want to understand two things: how well drugs distribute in these different lesion compartments, but also how drug tolerant the resident populations are. How much drug does it take
to kill these populations. And I'm going to first talk about how drugs distribute in these particular pockets. So we were fortunate a few years ago to have the opportunity to organize a clinical research study in collaboration with Cliff Berry and a few hospitals in Korea, where we took advantage of the fact that people who don't respond to therapy and have the option to have lung resection. So these people who chose to have lung resection, we obtained authorization to give them 5 drugs prior to surgery. And we timed the administration of these 5 drugs. So it was rifampicin, isoniazid, pyrazinamide as first line, moxifloxacin as the main second-line drug. There was also kanamycin. And we were fortunate that some of these patients were at steady state for clofazimine because it had been part of their background regimen. Okay, so we assigned 5 different time points to these 15 subjects in groups of 3. So they received the drugs at predefined times prior to scheduled surgery, either 2, 4, 8, 12, or 24 hours. And of course, this is a little bit difficult to organize because you cannot always have 100% confidence at the actual time of surgery, but this is as close as it got. And so we collected serial blood samples between the time of drug administration and the time of surgery. And then at the time of surgery, the big piece of lung that was resected was handed over to a pathologist, and that person then dissected out very carefully every single lesion they could find in this piece of lung. So nodules were dissected, but cavities were separated into cavity caseum and cavity wall. And we also tried to isolate pieces of uninvolved lung, as uninvolved as it gets. And so these pieces of material were then shipped to us, and we analyzed them 2 ways. We either homogenized them and measured the absolute drug concentrations by LCMS, mass spectrometry, or we performed multi-mass spectrometry imaging, which has been already shown by Kelly and by Eric. I'm going to explain to you in the next slide roughly how this works. So basically, the piece of lung that contains a lesion is sectioned in very thin sections, and those sections are then coated with a chemical. That chemical facilitates ionization of the drugs, which is required because only ions then fly to the detector and are counted. So what you can do with this system is, so this is the mass spectrometer. You put your section here. The laser shoots onto the section. The laser shoots pixel by pixel, and at each pixel, what the laser accomplishes is that its energy causes the ionization and desorption of the molecules of interest. Then they fly to the detector, and the detector counts them. So what you get is a heat map of the relative abundance of your molecule of interest in each pixel of this section. And then what you can do is superimpose this heat map onto the next section that has been stained by H&E. So then you can have a rough idea of where your drug is most abundant relative to the underlying structure of the lesion, or where it is actually less abundant. So in the next few slides, I have always highlighted the caseous center in either white or black lines, so you see the difference, the partitioning between the caseum and the cellular region. So this is a quick snapshot of the typical behavior you might see of 3 very different anti-TB drugs. So again, highlighted in white is the caseous center, surrounded by the cellular rim and the less involved lung. So you can have something like pyrazinamide, which Eric has already talked about, which distributes very evenly and rapidly into all lesion compartments, just like plasma, actually. Its concentrations in plasma, in lesions, in caseum are exactly the same. So you can use plasma PK for pyrazinamide when you do PK/PD analysis. It's just exactly the same as in lesions. And it doesn't bind either. So it's the perfect textbook example. Then you have things like moxifloxacin, which accumulates more favorably into cells than into caseum, but still does diffuse into caseum to some extent. And then you have at the other end of the spectrum, and it's great because Eric has talked about clofazimine, and I will not use it, I will not talk about it except for using it as an extreme example of very heterogeneous partitioning. So very poor diffusion into caseum and high accumulation into macrophages. So from here on, I'm going to focus on 2 drugs, and you will see why at the very end. I'm going to focus on moxifloxacin and rifampicin. So in the case of moxifloxacin, in all these subjects, we saw the same picture. We saw a very good partitioning in the cellular regions of granulomas and cavities, but not as good diffusion into caesium. And this was a function of the cellularity of the caesium. So the more cellular the caesium was, the better the diffusion of moxifloxacin. So sometimes you have cavity caesium, caesium comes into many colors and shapes. Sometimes you have caesium that's very neutrophil rich, and in that caesium, actually, moxifloxacin accumulates and diffuses much better than in caesium that's pure dead material. So this is, of course, just a visual impression, and it's not quantitative. That's one of the major drawbacks of MALDI imaging, is that you get a good sexy image, but you don't really know how much is there. So we complemented this with standard mass spectrometry. So what we did is that we had, out of the 15 subjects I talked to you about, 8 had cavitary TB. And more than 8 had cavitary TB, but we managed to keep those cavities sort of intact and to dissect out the caesium from the cavity wall. And so in these 8 subjects, which are here, we've measured moxifloxacin concentration in the cavity wall. Those are the gray bars. And in the cavity caesium in yellow, and as well as in plasma. And so what you see is that even though you have inferior diffusion into caesium, it's not that bad. It's as good as in plasma. It's not a function of how many doses the person has received, by the way. Some of these subjects were at steady state for moxifloxacin, but it doesn't accumulate over time. So it goes into the tissues early during the dosing interval, and then it comes out just as plasma. So this is moxifloxacin. And then rifampicin initially seemed to give us a similar picture. So we imaged it in a bunch of patients that had received only that one dose on the day of surgery, and it very much looked like moxifloxacin. So good distribution into the cellular regions, and then it starts to creep into the caesium, but it really doesn't diffuse all the way into the core of the caseous center. So this is the time post-drug administration. But then there was this guy who was 22 hours post-administration of the single dose, and then it looked like, even though most of it had gone from the lung lesions, from the lung tissue and the cellular regions, there was some sort of favorable distribution into caesium. So then we looked at steady state, and the picture was the total opposite. So basically, in patients who have received rifampicin for several months, what you have at the very end of the dosing interval, this is 26 hours after the last dose of rifampicin, is a marked accumulation into the caseous centers of this cluster of closed lesions, and a marked accumulation in the caesium of this cavity. So that goes back to Nicolas' question, and I wasn't going to talk about it, but I'm going to make a little digression. So basically, we do not understand rifampicin very well, but for all other drugs, this business about partitioning into caesium is a function of 2 things. It's a function of binding to macromolecules. So if binding is really high and the free fraction is really low, the diffusion into caesium, where there's no active vascularization to just help pouring drugs into it, is poor. But it's also a function of accumulation into macrophages. I want to say uptake into macrophages. So drugs that are really avidly taken up by the macrophages, like clofazimine, on top of having a very small free fraction that diffuses freely through the caesium, you have the macrophage layer that constantly pulls the drug into it. So this leads to this very unfavorable partitioning into caesium. For rifampicin, we're not sure. It's complicated because it's binding to macromolecules and its uptake by macrophages is in between. So it seems to sit in a sweet spot that we wish we had other drugs to test this hypothesis, but we only have rifampicin so far. Okay, so this is all about PK. So this is all about drug levels, but it really only takes full meaning if you understand how much drug is required to kill the resident populations. And this is something that we started recently. So just one last thing is that we confirmed by standard mass spectrometry that indeed, in the caesium of this cavity, the levels of rifampicin is significantly higher than in the cellular granulomas and in the cavity wall. So now let's talk about how much drug it takes to actually kill bacteria in caesium. And the reason that we want to do this is because we're really focused on lesion pharmacokinetic pharmacodynamics, and so by now we have figured out how much drug is present in these lesions over time. But what we really don't know is where to put that line. Of course, we have things like MIC and MBC, but how does that relate to the concentration that's required to kill, for example, extracellular bacilli inside the caseous core of a cavity or of a granuloma? Well, it could very well be that the concentration is actually higher than is ever achieved. So we started to do this with rabbit caesium, because human caesium is a little bit too precious to start playing around with drugs in a test tube. So we infected rabbits for approximately 16 weeks. This is how long it takes when they decide to cavitate, which is not always the case. So our model is not as nice as the one that Kelly has. And so we scooped out the caesium of these rabbits and aliquoted it into 96 well plates and added drugs at decreasing or increasing concentrations. And so these plates were sealed, and we incubated for 7 days at 37. And the first question that we wanted to ask is, are these bacteria really non-replicating, as the dogma goes? So what we did is that we took 7 different batches of caesium from different cavities, and we looked at how many CFUs were present on day 0 compared to day 7. So one thing that is important to say is that we did not spike bugs into caesium. We took advantage of the resident bacilli that were present in those caesium samples. And so what you can see in these seven different batches is that all in all, they don't die, they don't replicate it. So not much happens to them. So it's a true non-replicating model of drug susceptibility. And then we looked at the first, 3 of the 4 first-line drugs, isoniazid, pyrazinamide, and rifampicin. So this is the concentration in micromolar. So we went really high, so 1,000 micromolar, so 1 millimolar, even 10 millimolar for pyrazinamide. And so you can see that isoniazid, which has the reputation of not being very active against non-replicating bacilli, doesn't really work at all. I mean, we can see a little drop, but you have to go extremely high in concentrations that are not really achieved clinically. Pyrazinamide does show a few log reduction at very high concentrations. Now, pyrazinamide is a very small drug. So 1 millimolar of pyrazinamide is 100 micrograms per ml. So basically, here is 100 micrograms per ml. So these are concentrations that actually are achieved clinically to some extent. But of course, the huge and really nice surprise was rifampicin. So basically, rifampicin completely cleans up the caesium at sufficiently high concentrations. And so far, this is the only drug class for which we have seen this. I'm not going to show you other rifamycins, but suffice to say that rifapentine, rifabutine, and rifalazil all behave like rifampicin. They're actually even more potent. So then we looked at a few second-line drugs, and of those, really, moxifloxacin was the one that stood out. So moxifloxacin kills a 3 log of those resident bacilli at relatively high concentrations, but it really is the only one we looked at that had this behavior. Neither linezolid or kanamycin or clofazimine had significant activity against those populations. So I wanted to put this in the context of all these trials that were published recently about the potential for moxifloxacin-containing regimens to shorten treatment duration. Until recently, I used to think that it was clear that moxifloxacin was not present at sufficiently high concentrations to really kill the non-replicating bacilli into caesium. But this very recent piece of new data that we've acquired made me revisit this question very much. So here, what people did is that they replaced, I mean, you're all familiar, but just in case you're not. So either isoniazid or ethambutol was replaced by moxifloxacin for the first 2 months, and then the continuation phase was the same. And in this other trial, moxifloxacin replaced isoniazid, and then in the continuation phase, it was moxifloxacin and rifapentine instead of INH and rifampicin. But in both cases, they were not able to prove that a 4-month regimen was at least as good as a 6-month regimen. So why? Why did moxifloxacin not perform better in these trials? Because this is work that we've done with Radha Savage. Because if you put can you see the yellow window? Okay, so if you put a yellow window that corresponds to clinically achieved concentrations inside caesium, you get the picture that actually moxifloxacin is just as good as rifampicin. So basically, at clinically achieved concentrations in caesium, you get a 2-log kill with moxifloxacin like you get a 2-log kill with rifampicin. So why is it that moxi didn't show off better than it actually did? And this is just a question I put on the table. We have no proof, it's a hypothesis, but something to think about in future clinical trial. Is it possible that actually moxifloxacin's activity was masked by rifampicin, that they both target roughly the same bacterial population? Rifampicin might be a little bit better at it because it sticks in the caesium throughout the entire dosing interval, which moxifloxacin may not be able to do. But at the end of the day, perhaps that's what happened. And there's also a paper that I read at the time, and I didn't think much of it. But it's a paper by Tawanda Gumbo and George Drosano. Actually, Tawanda is not on this one. It's a paper by George Drosano showing that against non-replicating bacilli in the hollow fiber system, there is an antagonism between moxifloxacin and rifampicin. So I think the conclusion of all this is that moxifloxacin might very well be the rifampicin of MDR drug regimens. Eric's talk actually made me think, it could be a good partner for clofazimine. But it's never really been tested because if you think about it, all very long and expensive clinical trials that have been run with moxi always had rifampicin. So this covers most of what I have said. I don't think that I need to go through this. I just want to acknowledge a lot of people in our lab, and a lot of what I've talked about today was done in collaboration with Cliff Berry and Laura Vaya. Thanks.
Thanks very much, Veronique. I may use the privileges to ask you one question. So what you're suggesting is that there is local monotherapy in the caesium. Is that right?
Yeah, I didn't emphasize this today, but it's very clear from the images that I have shown that even though we think we're giving 4 drugs, for example, at any given point in time or at any given spot in the lesion, we might not have 4 drugs at therapeutically relevant concentrations. We might actually end up with just 1. And this explains why, even in the face of 4 drugs, resistance emerges against tuberculosis.
Thank you. I think we're running very much over time, but we can allow one question.
My question is about the accumulation of rifampin in the caesium, connected to possibly the lack of the high-dose rifampin studies to really increase efficacy. And could it be that I'm thinking like a sponge, and it's kind of already saturated with enough rifampin. Adding more, maybe you'll have higher plasma concentrations, but do you think there's any relationship between that accumulation of rifampin and caesium with really not much more efficacy with higher doses of rifampin?
It's possible. I think also there's intervariability of plasma concentrations with rifampicin, but I think you're right. It's something that we should explore. What drives the diffusion of rifampicin into caesium and what makes it stick there is binding, and it's 93% bound to caesium macromolecules. I don't know whether it's possible that it saturated the binding sites. I think probably not, but it's a good hypothesis.
You have the very high partitioning, relative to caesium, and then if you look at your kind of extracellular or intracellular killing curves, I mean, you're probably up higher on that dose response curve than just plasma concentrations would
Agree.
suggest.
Something to explore if we find the right experimental design.
Wow.
Good.
Our final speaker is Dr. Heinrich, who will be talking about examples, learnings, better trials, and regimens.
So thanks very much, Andy. I think this title was sufficiently vague to start a talk which is basically composed of wild speculations. And I think what we've heard up to now fits not too badly with that. So let me start work. Okay. So, yeah, what we've heard is to bring it all together is that the TB treatment science has a lot of new answers that increase our knowledge. We have liquid culture. We know about resuscitation promoting factors and lipid-rich cells. We have whole genome sequencing, transcriptomics. We have necrotic granuloma mice, and we know about lesion drug concentrations. But to me, what was the question again that these things answer to us for drug development? And a bit of speculation might help here. So back to the basics. What we are trying to achieve is a shorter treatment regimen for all sorts of TB, which is limited currently by the relapses that we are seeing with shorter treatments. As you're familiar with, in the REMOX study, there was quite a higher relapse rate after 4 months of treatment compared to 6 months of treatment. In fact, Bob Wallace's model showed us again, in addition to all the Medical Research Council studies from East Africa, that relapse is actually a factor that dictates treatment duration. In addition to treatment duration, there is the biomarker of month 2 culture positivity. So if we want to have a shorter treatment, we will have to achieve a lower month 2 culture positivity rate to have an acceptable relapse rate after the treatment is completed. Now, I would suggest that we leave the biomarker away for a second and just focus on relapse itself to see what we'd like to know and what is actually known. What we'd like to know is, of course, the metabolic state which allows bacteria to survive the treatment that we are giving to the patients, hoping that this will inform us on how to kill those bacteria that would cause the relapse otherwise. We would like to know the localization that permits the bacteria to survive treatment within lesions in order to optimize treatment that it would reach this localization. And finally, we would like to know what determines the timing of regrowth and relapse. So I may expose myself now with a few lacks of knowledge and hope you will help me then in the discussion, but try to attempt to summarize what we know about this. The published risk factors for adverse outcomes are, of course, if a patient has a cavitation in chest X-ray from the REMOX data set, if there are higher percentages of lipid body containing bacteria in sputum, as published by Derek Sloan, with a limitation that this was a composite outcome of failure and relapse. And what we know from transcription studies is that patients who later experience relapse can be identified at baseline by having an excessive cytolytic response when their PBMCs are challenged with TB bacilli. So something seems to be different about their immunity compared to patients who achieve a lasting cure. Together with this, HIV co-infection and being of male gender seems to be a bad thing in this respect. So what we know about timing of relapse is that most relapses occur relatively early after treatment. In this summary by Andrew Nunn, we can see that 87% of all relapses occur in the first 6 months of treatment and only very few afterwards. And this was a time when relapse and reinfection could not be differentiated. So I think this might have something to do with the kinetics of lesion healing and stabilization. So let's start speculating. And thanks again, Veronique, for this wonderful image. Not only your mass spectrometry, but also this is making our presentations richer. A possible sequence of events might be that first, the bacteria which are here in this intracellular compartment are cleared by treatment. And this might, in some way or other, correspond to patients turning sputum negative. And then, when the inflammatory stimulus goes away, of course, we'll see a downregulation of this inflammation, this what I call hyperinflammatory state, which leads to cell turnover and necrosis. And finally, we'll see then a process starting that I would call healing or stabilization, or maybe healing and sealing. And in histology, we'll see that these lesions start acquiring a really large fibrotic rim, which somehow encloses their contents. During this process, we would probably see new phagocytes coming in and eating phagocytosing bits of the caesium, and the still contained persisting bacilli in there, as Veronique has shown us, that it's relatively doubtful that we would clear all persisting bacilli in this caseous material with our standard treatment to date. And of course, we know that TB bacilli intracellularly do quite well, so they would be expected to start proliferating and causing another bout of inflammation. And in those patients, as we've seen, who go on to have relapse, there seems to be some difference with immunity against TB, so this would then be expected to be insufficiently controlled. Now, our current long treatment regimen would be expected to span enough of this time until the lesion is sufficiently stabilized and nothing can get out of it anymore. But when we shorten this to, ambitiously to 3 months, then of course there is no drug around anymore when persisting bacilli would come out of the caesium and be able to proliferate again. Now, if you agree with me, I would just go forward and try thinking about a few strategies that we would derive from this to compose our treatment regimen. Of course, the most obvious is that we would develop new drugs and dosing regimens that would allow us to sterilize the lesion completely, including the caesium, and to do that in a very short time as compared to now, which is probably ambitious. And then we know that there are drugs such as clofazimine or bedaquiline, which do not penetrate the lesion to a great extent, but have a very long half-life, which makes them stay around the necrosis in the cells for months after the end of treatment. And you'd expect that any bacilli that are phagocytosed and come into a more favorable location for proliferation would meet enough of that drug to be killed. Now, we've just mentioned effective monotherapy. This would be another instance of monotherapy, but fortunately, we seem to have 2 drugs with bedaquiline and clofazimine, which do something like that. Unfortunately, they seem to share a mechanism which lowers the bug susceptibility to those. But perhaps Q203 might be a drug that has properties similar to those 2 and has a different mechanism of resistance. And then finally, if we are less ambitious, we would just think about shortening the time to a stably healed lesion from which nothing can come out anymore. And that could be done by clearing the intracellular bacilli around the necrosis faster, abbreviating the time of destructive inflammation and necrosis, and allowing earlier healing and sealing of this lesion. And potentially host-directed therapies might also help in this treatment strategy. We should, of course, all do this minding a regimen's sustainability. That means how long can it be used before we see significant resistance. And I'm particularly concerned about drugs which have a really long half-life and would not have any partner drugs around when bacteria are exposed to those drugs. So back to my first slide. The question that we have more answers to is about relapse. And I would like to acknowledge, of course, the Panacea Consortium and our collaboration partners. And you for hanging out until this very last session and the end of this session. And it would be great to keep on speculating in the future to see how we can get to more effective drug regimens, backed by evidence, of course. Thank you very much.
I think we could entertain questions for any of the speakers at this point. I have one for Veronique. You mentioned that in your, what I took to be your in vitro evaluations, that the other rifamycins appeared to perform as well or even better than rifampin, but that did not consider their penetration, if I understood properly. So I wonder if you could enlarge a little bit on your current thinking about the comparisons amongst the rifamycins. I can hear you.
So we're currently looking at this in collaboration with Anne Leonards. So we're taking all 4 clinical, I don't know that rifamycin is considered clinical, but rifamycins, and we're going to look at the lesion pharmacokinetic, pharmacodynamic relationships in chronic mice. So hopefully we're going to be able to rank them and to understand their potential for patient regimens for patients. So rifabutin, rifapentin, and rifalazine are all 10 times as potent as rifampicin in this caesium bactericidal assay. Now you have to take into account the fact that in this caesium they are 99% bound. Rifapentin, rifabutin, and rifalazine, they're bound like crazy. We've measured this. So this is important. I always say this because it doesn't matter, right? Either they're extra super potent and the free fraction is less than 1%, and that's what accounts for 10 times more potent than rifampicin. Or binding is not that important. It's a dynamic equilibrium between binding to macromolecules and being gobbled up by TB. I mean, something to think about. I actually like that. But then you're right, Andy. So basically, we have to put this in the context of distribution into caesium. We only know so far about rifapentin, but we do know that its diffusion into caesium is inferior compared to rifampicin. It just does not. We haven't looked long term. We will, but when you've just reached steady state, it's creeping into caesium, but it doesn't cover it like rifampicin does.
I guess as I think about one of the things that it occurs to me, of course, that's a static model, and the cavities you're looking at are in the patients who, in a sense, are just beginning some effective therapy in some way. At least it hasn't worked well up until this point because the cavities are being taken out because they're not going away on their own. So these are patients who, in some sense, are failing therapy, and you wonder what's going on in patients in whom therapy is succeeding, and what are the kinetics of those events and the timing, and how all these factors will play together. So it's really fascinating to follow this. Other questions?
I understood what Veronica said. I thought that she said that these were patients with, and perhaps you'll clarify, that these patients had been on therapy for a long time. What she gave, I assume, was the radio label for the quantitation half of the experiment.
So no, I didn't explain that. Basically, multi-mass spectrometry imaging detects drugs by mass, so there's no need to label anything. So you can recognize it on the spot. So those images, you're talking about the images?
No, I'm talking about the identification in the mass spec process itself. These patients were on these drugs for quite some time before the drug, and then got a label to check diffusion?
So these patients were on a second-line regimen.
These drugs not given?
So these drugs were given once on the day of surgery.
Oy,
most of the time.
Right.
Yeah.
This is like karaoke, isn't it?
No.
Maybe I'll swap you. You know, believe me, you don't want me to sing. I'm just thinking how to phrase this. So I have a slightly more general question. I guess it's to all the speakers, because I think this has been a great session, and I think putting these kind of data together is always very enlightening. So the question I have is, generated by our observations from looking at mouse data and human data together. And I think what we are seeing is that EBA 0 to 2 and that kind of very early readout is not really a very good proxy at all for for the predictions that are made by mouse models. And I think some of what I've heard is very fascinating. So I guess one of the questions is, do we have now in vitro tools that will enable us to accurately predict the first phase of EBA, in the sense that we would no longer be deceived by that in clinical development? I'm not that surprised from what you say, Vera, that clofazimine doesn't show any EBA, but I am slightly surprised by the fact that isoniazid doesn't do better in caseum. So the thing that I was thinking was, we're capturing perhaps those populations, caseum and intracellular populations, quite well in your assay and in the mouse model, but what about the third population? What about the population that exists in the rim of the lesion that may be more actively replicating? Do we have good models for that? And is that important in clinical development, I wonder?
That's a great point, because I know that for 10 years, when we would listen to Professor Mitchison point out that the great mass of bacilli were in the cavity wall, and that's where the large numbers of bacilli were. And that's sort of not in our view at this point. And any thoughts on that from the studies you're doing, Veronique? Are you seeing the large mass of bacilli in the cavity wall in the sections you're looking at?
It's animal model specific, but what we're trying to develop is an in vitro assay that looks at the activity of drugs against replicating bacilli in foamy macrophages, which is really the cellular layer that's directly outside of the caseum, which we think is important, because when you think about it, this population of cells that's constantly pour, they necrotize and they pour bugs into the caseum. That's our next challenge.
This is really fascinating. I really want to, I think we should let people go. Oh, go ahead. Go ahead. No.
I can talk to Jerry afterwards, too.
I want to hear it.
I was going to say, I think more exploration of more chronic cavities is really critical in animal models, and so we've certainly been trying to develop such a capacity in the Kramnik mice. Obviously, rabbits and other things may be useful, and I think there are a lot of interesting questions, and that is where, how many of these bugs are there? What's the localization, if you will, and also I think. There's been a lot of speculation over time that perhaps even something akin to a biofilm forms along, the inner rim of some of these more chronic cavities in patients, which of course is a very, pharmacologically privileged site, or pharmacodynamically privileged site, certainly. And so, I think that's really probably been underexplored as well in whether in preclinical or, clinical pathology studies. So I do think there's a lot to learn, and I've always been interested in the the relationship between looking at a lot of these pathology samples are where the caseum is intact, and it's not necessarily maybe tantamount to looking at this liquefied rim of caseum in a chronic cavity, and I think. There's just always going to be more we can do to try and correlate with with what's really happening in patients. Yeah.
I want to thank all the speakers for a really superb session. I'll leave you with one thought to challenge all of you, and that's whether we are sufficiently thinking about things we can do from the perspective of the bacillus. It occurred to me as I was listening to people today that the goal of the bacillus is really symbiosis. They're not trying to conquer humans. They want to have a nice niche to survive in. And the state of LTBI, of stable LTBI, might be the best example we have of exactly what is the ideal circumstance from the bacillus's point of view, which means that disease is not only a totally undesirable situation from the point of view of the host, it's totally undesirable from the point of view of the bacillus. And so as we try to reestablish this balance, we might think about whether there are things we can recruit from the capacities of the bacillus to help us in all this. The issue of, yes, some people with LTBI will develop disease in the future, you could say it refutes my proposal, but actually that's a problem the bacillus can't help with. The problem is the host failed to keep up their part of the bargain by maintaining adequate immune control. So I'll leave you with that thought, and thank you all for coming.